So the partnering agencies recognize that there is a service gap in the mainstream mental health landscape, that many racialized refugee and immigrant populations don't have access to mental health services, either because they feel the services aren't accessible to them or because the services aren't targeted to that population and to their specific needs. And so this partnership seeks to address that gap by trying to provide culturally sensitive, trauma-informed, CBT-related mental health care services for immigrant, refugee, and racialized populations.
One of the major gaps would be around workflow. With the recognition that we saw similar clients, what we found is that we would have a client coming into women's health, specifically for mental health. However, they may need more advocacy or they may need different kinds of services.
And so the agencies work together to provide those services to ensure that there's coordinated referrals and to ensure that if a client comes to our agency for those services, that they're either able to access those services at our agency or able to be referred in a timely and appropriate way to other agencies.
So in this partnership, what my role was, I was one of the co-facilitator. My colleague Laurie Simonovic was the other one. So we met with leads from the other organization to do a needs assessment in terms of what educational capacity they are looking for. And then we modified the training manual, and then Laurie and I delivered the training. So we focused on the capacity building component of the partnership.
So Sherburne Health Center participates in this partnership by providing direct services to newcomer communities. And at the moment, we've begun our piece of this project by prioritizing mental health services in St. Jamestown.
CCVT has a very long history of providing services to survivors of torture and war, and so CCVT recognizes the very unique and significant mental health needs of this population group. And so it was very clear that this is a service that is needed and it could enhance the lives of clients if they have increased access to mental health services that address their specific needs.
We're able to connect, for example, schematic considerations or environmental considerations with the cultural. And I find that's golden in terms of being able to actually reach the client.
So when we first began, I was probably at the St. Jamestown Community Corner for 7 hours and only saw 2 clients. So if we didn't understand measurement of success well, we would think that we aren't serving our community. But in fact, if we reorient the way we think about the work we do, we would think about that as an initial phase of building rapport with the community we want to work with. And so coming from that angle, we were able to establish a kind of cultural safety and a presence in the St. Jamestown and newcomer community. And now I've got a full roster of clients. So we've begun to reach new people in a community that we identified as being high needs at the outset.
I mean, for clients, they have access to a service that they might not otherwise have access to in across the mainstream service providers. Mm-hmm. And so this benefits their mental health and that they're able to navigate that mental health system a bit better. They're able to learn tools to practice self-care, to take care of themselves.
There is a fundamental moment in your therapeutic relationship where you realize that the client gets that you get it. It's precious as a practitioner to have your client see you and see that you see them.
At the day of the training, it was really good to see people having conversations about equity issues and kind of like learning from each other what some of the issues and challenges one organization might have that another one can learn from. It was very participatory in that sense. And then the other thing is just myself had a better understanding of what local organizations, the services they offer. So that was really good just for me, so that when I do training with other organizations, I can refer back to this partnership and say, oh wow, you know, Women's Health to Women's Hand, they do these really amazing programs. This is what it looks like, or the Center for Victims of Torture. So I just have a better understanding of the organizations as well.
Well, I hope that the partnership continues, that right now the agencies are in close contact. We meet approximately, once a month to talk about activities and events and how to make the project flourish and better. And so hopefully that will continue so that the partnership grows.
What would be ideal would be that there is knowledge translation that incorporates from a quantifiable place the benefit of moving a theoretical model forward with the cultural dynamic, the systematic dynamic, recognition of stigma, recognition of barriers, recognition of challenges.
And also that the partnership eventually leads to increased knowledge and best practices, which will not only enhance the services provided at each agency, but that knowledge can also be disseminated across, other agencies and across the sector that works with immigrant and refugee populations, so that the services can be enhanced across not only these agencies, but across many others, so that clients continue to have access to accessible and equitable services.
What I would recommend in terms of any partnership is to really look at issues of power. What are the power relationships between and among each partner? Some would have more, some would have less. Looking at what's the knowledge, what's the expertise, what's the resources each organization have and how they can share those as well. Building on the strengths of each organization. So that as a whole, the partnership can succeed.
In terms of best practices, I think people are always looking for best practices, but one thing to keep in mind is that we're all doing mental health work, and it's already probably quite effective. What we have to think about is documenting what we're already doing and how we're already adapting clinical models such as cognitive behavioral therapy, psychodynamic approaches, talking about mental health in ways that make it relatable, and thinking about how do we adapt some of these models so that they seem really accessible to people. And I think that we have to continue to establish what the best practices can be together, because what best practices look like are going to vary depending on whether you're focusing on a geographical community or if you're working with a particular ethno-specific agency. So it's thinking about what speaks to that community and documenting how we adapt service so that it's relevant.